disorders of ocular motility, anatomy and physiology of ocular motility system. Extraocular muscle, a set of 6 extraocular muscle, 4 recti and 2 obliques control the movements of each eye. Origin insertion, rectus muscle origin from a common tendinous ring, annulus of gin, which is attached at the apex of orbit, encircling the optic foramina and medial part of superior orbital fissure. These are the extraocular muscle and origin of rectus muscle and superior oblique muscle. This one is superior oblique muscle. This is levator pupilli. This is superior oblique. This is medial rectus and optic nerve, ophthalmic artery, annulus of gin, inferior rectus, superior orbital fissure and inferior ophthalmic vein and oculomotor nerve, obtusen nerve, nasociliary nerve, oculomotor nerve, lateral rectus muscle and superior ophthalmic vein, lacrimal nerve, frontal nerve and trochlear nerve. These are the extraocular muscles. Optic nerve, medial rectus, inferior rectus, this one is medial rectus, inferior oblique, lateral rectus, superior oblique, superior rectus, then trochlea. Then medial rectus arises from medial part of ring, superior rectus from superior part of also adjoining dura covering the optic nerve, inferior rectus from the inferior part and lateral rectus from the lateral part by two heads which join in a V form. All the 4 recti run forward and around the eyeball and are inserted into sclera by flat tendons about 10 mm broad at different distance from limbus at under medial rectus 5.5 mm, inferior rectus 6.5 mm, lateral rectus 6.9 mm, superior rectus 7.7 mm. Superior oblique muscle arises from the bone above the middle to optic foramina. It runs forward and turns around a pulley, the trochlea, present in the anterior part of superior medial angle of orbit and is inserted in the upper and outer part of sclera behind the equator. Inferior oblique muscle rises by a rounded tendon from oblique orbital plate of maxilla just lateral to orifice of nasolacrimal duct. It passes laterally and backward to inserted into lower and outer part of sclera behind the equator. Nerve supply third cranial nerve, fourth cranial nerve and sixth cranial nerve. Third cranial nerve supplies the superior medial and inferior and inferior oblique muscle. Fourth cranial nerve, trochlear supplies the superior oblique, SO4 and LR6. Then action, the extraocular muscle rotate the eyeball around vertical, horizontal and anterior posterior axis. Medial and lateral rectus muscles are almost parallel to optic axis of the eyeball, so they have got only main action, while superior and inferior rectus muscles make an angle of 23 degree and reflected tendons of superior and inferior oblique muscles of 51 degree with the optical axis in the primary position, so they have subsidiary actions in addition to main action. Action of each muscle figure 4.6 are shown in table 14.1. We'll see in further. Ocular motility, types of ocular motility: adduction, abduction. Adduction is inward movement and abduction is outward movement. Adduction is medial rotation, abduction is lateral rotation. Insertion lines of extraocular muscles on sclera as in front, above, C behind and S are superior rectus, M are medial rectus, in I are inferior, lateral rectus, L are S for superior oblique and inferior oblique. S are M are I are L are. Okay, then medial rectus is inserted here, tendon of superior oblique muscle, insertion line of superior rectus muscle, then lateral rectus muscle, superior oblique and superior vertex vein, inferior oblique, inferior vertex vein, insertion line of lateral rectus, superior rectus. Relation of superior and inferior rectus muscle with optical axis in primary position. This one is optical axis and 23 degrees superior rectus. Relation of superior and inferior oblique muscle with optical axis in primary position. Superior oblique muscle, muscle plane 15 degree optical axis, medial rectus, lateral rectus, LR. Then this one is abduction, this is adduction, medial rectus. Then superior rectus, adduction, internal rotation, elevation. Then Inferior oblique is abduction, extension and elevation. Then inferior rectus is adduction, extension and depression. Superior oblique is abduction, internal rotation and depression. Then this is intrusion, this is extrusion. Then supraduction, it is upward movement, elevation along the horizontal axis. Infraduction, it is downward movement along the horizontal axis. Encycloduction, intorsion, it is a rotatory movement along anterior posterior axis in which superior pole of cornea moves medially, and internal rotation. Excycloduction, it's a rotatory movement along the anterior posterior axis in which superior pole of cornea moves laterally. External rotation. Binocular movements, these are two types: versions and versions known as conjugate movements or synchronous symmetric movements of both the in the same direction. These include dextroversion, it is the movement of both eyes to right side. It results due to simultaneous contraction of right lateral rectus and left medial rectus. Levoversion, it refers to movement of both eyes to left, produced by contraction of left lateral rectus and right medial rectus. Supraversion, it is upward movement of both eye in primary position. It results due to simultaneous contraction of bilateral superior recti and inferior oblique. Infraversion, it is downward of both eye in primary position. It results due to simultaneous contraction of bilateral inferior recti and superior oblique muscle. Dextro elevation is movement to right and upside. It is caused by simultaneous action of right superior rectus and right inferior oblique. Dextro depression, it is movement to right and downside. It is caused by simultaneous action of right inferior rectus and left superior oblique. Levo elevation, it is movement to left and upside. It is caused by simultaneous action of left superior rectus and right inferior oblique. Levo depression, it is movement to left and downside. It is caused by simultaneous action of left inferior rectus and right superior oblique muscle. Dextrocycloversion, it is rotational movement around the anterior posterior in which superior pole of cornea of both eye tilts towards the right. Levocycloversion, it is just the reverse of dextrocycloversion. In this, superior pole of cornea of both eye tilt towards the left. Vergence is also called disconjugate movements or synchronous symmetric movements of both eye in opposite direction. Convergence, it is simultaneous inward movement of both eye which results from contraction of medial recti. Divergence, it is simultaneous outward movement of both eye produced by contraction of lateral recti muscle. Synergist refers to muscles having similar primary action in same eye. Antagonists, these are muscles having opposite action in the same eye. For example, medial and lateral recti, superior and inferior recti. Yoke muscles, contralateral synergists, these refer to pair of muscles which contract simultaneously during version movements. And for example, right lateral rectus and left medial rectus are yoke muscles for dextroversion movements. Contralateral, and these are pair of muscles having opposite action. For example, right LR, left LR, right MR, left MR. Hearing's law of equal innervation. According to law, an equal and simultaneous innervation flows from brain to a paramuscle which contract simultaneously in different binocular movements. Example, during dextroversion, right lateral rectus and left medial rectus muscles receive an equal simultaneous flow of innervation. During convergence, both medial recti get equally innervated. During dextro elevation, right superior recti and left inferior oblique receive equal and simultaneous innervation. Diagnostic positions of gaze: primary position, secondary positions. Secondary position B, D, F, H. Primary position E. Cardinal position A, C, G, F, I. Sherrington law of reciprocal innervation. According to it, during ocular motility, increased flow of innervation to contracting muscle is accompanied by decreased flow of innervation to relaxing antagonist muscle. For example, during dextroversion, an increased innervation flow to right LR and left LR is accompanied by decreased flow to right MR and left LR muscles. Diagnostic positions of gaze. There are 9 diagnostic positions of gaze. These include 1 primary, 4 secondary, and 4 tertiary positions. Primary position of gaze. It is the position assumed by the eyes when fixating a distant object with erect position of the head. Secondary position of these are positions assumed by the eyes while looking straight up, straight down. Tertiary position, these describe the position assumed by the eyes when combination of vertical and horizontal movements occur. These include position of eyes and dextro elevation. Dextro depression, levo elevation, and levo depression. Cardinal position of gaze. These are told allow examination of each of the 12 extraocular muscles in their main field of action. There are 6 cardinal positions of gaze with dextroversion, levoversion, dextro elevation, etc. Supranuclear control of eye movements include saccadic smooth muscle, Vergence vestibular system, etc. Optokinetic system. Saccadic system. Saccades are sudden, jerky, conjugate eye movements that occur as the gaze shifts from one object to another. Thus, they are performed to bring the image of an object quickly on the fovea. Though normally voluntary, saccades may be involuntary, aroused by peripheral visual or auditory stimuli. Smooth pursuit eye movement or tracking movements of eye as they follow moving objects. These occur voluntarily when eyes track moving objects but take place involuntarily if a repetitive visual pattern is displayed continuously. When the velocity of moving object is more, the smooth pursuit movement is replaced by small saccades. Vergence movements allow focusing of an object which moves away from or towards the observer, or when visual fixation shifts from one object to another at different distance. Vestibular movement system. Vestibular movements are usually effective in compensating for effects of head movements and disturbing visual fixation. Optokinetic system. The system helps to hold the images of scene world steady on the retina during sustained head rotation. This system becomes operative when vestibular ocular reflex gets fatigued after 30 seconds. Position maintenance system. This system helps to maintain a specific gaze position by means of rapid micro movements called flicks, slow movements called drift. This system coordinates with others. No neural pathway for this system is believed. Binocular single vision. When an normal individual fixes his attention on an object of regard, the image is formed on the fovea of both eyes separately, but the individual perceives a single image. This is called binocular single vision. Development of binocular single vision. Binocular vision is conditioned reflex which is not present since birth but is acquired during first 6 months and is completed during first few years. Important milestones. At birth there is no central fixation. The eyes move randomly. By first month of life, fixation reflex starts developing, become established in 6 months. By 6 months, macular stereopsis, accommodation reflex. 6 years when the visual acuity is attained and binocular single vision is well developed. Prerequisite for development of binocular single vision: straight eyes, reasonably clear vision, ability of visual cortex to promote binocular single vision. Grades of binocular single vision: grade 1, simultaneous perception. It is a power to see two dissimilar images simultaneously. It is tested by projecting two dissimilar images in front of two eyes. For example, when a picture of bird is projected in right eye, that of cage on the left eye, and individual with presence of simultaneous perception will see the bird in the cage. Grade 2, fusion. It consists of this kind of fusion. It consists of power of to superimpose two incomplete but similar images to form one image. Then C is stereopsis. Stereopsis is it consists of ability to perceive the third dimension. It can be tested with stereopsis lights and synoptophore. Anomalies. There are many anomalies. Suppression. It is a anomaly of binocular vision. Suppression. It is a temporary active cortical inhibition of image of an object formed on the retina of squinting eye. This phenomenon occurs only during binocular vision with both eyes open. However, when fixating eye is covered and squinting eye is fixed, suppression disappears. Test to detect the Worth's 4-dot test, 4 diopter base out prism test, and red glass test, synoptophore test. Amblyopia. Amblyopia by definition refers to partial reversible loss of vision in one or both eye, for which no cause can be found by physical examination of eye. That is, there is absence of any organic disease of ocular media, retina, and visual pathway. Pathogenesis. Amblyopia is produced by certain amblyogenic factors operating during critical period of visual development, birth to 6 to 7 years of age. During this period, the visual pathway continues to develop and brain learns to interpret signals that come from eye. Amblyopic the most sensitive period of development of amblyopia is first 6 months of life, and it usually does not develop after the age of 6 to 7 years. Amblyogenic factors include visual deprivation, as occurs in anisometry, tropia, light deprivation, abnormal binocular interaction. Example: strabismus. Types: strabismic amblyopia, stimulus deprivation, anisometric amblyopia, isoametropy amblyopia, meridional amblyopia. Strabism amblyopia results from prolonged uniocular suppression in children with unilateral constant squint to fixate the normal eye. Squint is most common cause of amblyopia. Stimulus deprivation amblyopia develops when one eye is totally excluded from seeing early in life, as in congenital or traumatic cataract, complete ptosis, and dense central corneal opacity. Anisometric amblyopia occurs in the eye having higher degree of refractive error than fellow eye. It is more common in anisohypermetropy than anisomyopic children. E1 1 to 2D Hypermetropic anisometropia may cause amblyopia, while up to 3D myopic anisometropia usually does not cause amblyopia. Isoametropic amblyopia is bilateral amblyopia occurring in children, bilateral uncorrected high refractive error. Meridional amblyopia occurs in children with uncorrected astigmatic refractive error. It is a selective amblyopia for a specific visual meridian. Clinical characteristics of amblyopia are visual acuity is reduced, recognition acuity is more affected than resolution acuity, effect on neutral density filter. Visual acuity when tested through neutral density improves 1 or 2 lines in amblyopia, decrease in patient with organic lesions. Crowding phenomena is present in amblyopia. Example, that is visual acuity is less when tested with multiple letter charts. Fixation pattern may be central or eccentric. Color vision is usually normal, may be affected in deep amblyopia vision below 6/36. Treatment of amblyopia should be started as early as possible. Amblyopia therapy works best when initiated in young children under 3 years of age. Occlusion therapy. Occlusion of sound eye to force use of amblyopia eye is the mainstay treatment of amblyopia. However, before the occlusion therapy started, it should be ensured that opacity in the media, if any, should be removed first. Refractive error, if any, should be fully corrected. Simplified schedule for occlusion therapy depending on the age is as follows. Up to 2 years, the occlusion should be done in 2:1. Then at the age of 3, 3:1, 4, 4:1, 5, 5:1, 6:1. Duration of occlusion should be until the visual acuity develops fully and there is no further improvement of vision for 3 months. Penalization, that is blurring of vision of normally either by using atropine or by using overplus lens in spectacles can be used as an alternative. Occlusion is not possible. Preoptic is recommended in the past to re-establish foveal fixation, especially in young children. Pharmacological manipulation using levodopa, carbidopa have been studied as an adjunct occlusion therapy. Perceptual learning is also suggested as an adjunct to occlusion therapy. Computerized visual therapy is using specially designed software as common to work for treatment of amblyopia with controversial results. Vision therapy works on the concept of operant conditioning. Computerized home vision therapy can be prescribed as supplementary treatment to occlusion therapy. Abnormal retinal correspondence. In a state of normal binocular single vision, there exists a precise physiological relation between the corresponding point of two retinae. Thus, the fovea of two eyes act as a corresponding points and have same visual direction. Adjustment is called normal retinal correspondence. When squint develops, patient may experience either diplopia or confusion. To avoid this, sometimes there occurs an active cortical adjustment in the directional values of two retinae. In this state, fovea of the normal eye and extrafoveal point and retina of squinting eye acquire a common visual direction, that is, become a corresponding points. This condition is called abnormal retinal correspondence. The child gets a crude type of binocular single vision. Diplopia refers to simultaneous perception of two images of single object. Diplopia may be binocular or unilocular. Binocular diplopia occurs due to formation of image on dissimilar points of two retinae. Cause of binocular diplopia are paralysis or paralysis, displacement of one eyeball, mechanical restriction of ocular movement, deviation of ray of light, and isometropia. Types: binocular diplopia may be crossed or uncrossed. Uncrossed diplopia, in uncrossed diplopia, the false image is on the same side of the deviation. It occurs as in convergent squint as in lateral rectus paralysis. Crossed diplopia, in crossed diplopia, the false image is seen on opposite side. It occurs in divergent squint as in medial rectus paralysis. Uniocular diplopia, though not an anomaly of binocular vision, but it will not be out of place to describe uniocular diplopia along with the binocular diplopia. In uniocular diplopia, an object appears double from affected eye when the normal eye is closed. Cause of uniocular diplopia: subluxated clearance, subluxated intraocular lens, double pupil due to congenital anomaly or large peripheral ectomy, hydrodialysis, incipient cataract. Usually polyopia, that is multiple images may be seen due to multiple water clefts. Keratoconus diplopia occur due to change in refractive power of cornea in different parts. Treatment of diplopia that treat the causative disease. Temporary relief from an eye diplopia can be obtained by occluding the affected eye. Strabismus. It is defined as normal visual axis of two eyes are parallel to each other in the primary position of gaze. A misalignment of visual axis of two eyes is called squintus strabismus. This alignment maintained in all positions of gaze. Classification: apparent squint, lateral squint, manifest squint, concomitant squint, and incombinant squint. Pseudostrabismus: the visual axes are in fact parallel, but the eyes seem to have squint. Pseudo-esotropia or apparent convergent squint: Prominent epicanthal fluid, which covers the normal visible nasal aspect of globe, gives a false impression of esotropia. Negative angle kappa. Pseudo-exotropia or apparent divergence could may be hypertelorism, positive angle kappa. Heterophoria, latent strabismus is a condition in which the tendency of eye to deviate is kept latent by fusion. Therefore, when the influence of fusion is removed, the visual axis of one eye deviates away. Orthophoria is a condition of perfect alignment of two eyes maintained even after removal of influence of fusion. However, orthophoria is a theoretical ideal. Practically, a small amount of heterophoria is of universal occurrence and known as physiological tropia. Types of heterophoria. Esophoria, lateral convergent squint, refers to tendency of eyeball to deviate inward. It may be convergent excess type, divergent weakness type, non-specific type. Exophoria, convergent weakness types, divergent excess type, non-specific type. Hyperphoria is tendency of eyeball to deviate upwards, while hyperphoria is tendency to deviate downwards. However, in practice, it is possible to use the term right or left hyperphoria depending on the eye which remains up as compared. Cyclophoria, a torsional deviation, is a tendency of eyeball to rotate around the anterior posterior axis. When the 12 o'clock meridian of cornea rotates nasally, it is called encyclophoria, and when it rotates temporally, it is called encyclophoria. Etiology. Untimely fetus response for development of heterophoria includes orbital asymmetry, abnormal interpupillary distance, wide IPD associated with exophoria, and small with esophoria, faulty insertion of extraocular muscle, mild degree of extraocular muscle weakness, anomalous central distribution of tonic innervation of two eyes, anatomical variation in the position of macula in relation to optical axis of eye, physiological factors, age, younger age, more common in age, rule of accommodation, increased accommodation is associated with esophoria, rule of conversion, excessive use of conversion may cause esophoria, while decreased use of conversion is often associated with exophoria. Dissociating factors such as prolonged constant use of one eye may use exophoria, as occurs in individuals using intraocular microscope and watchmakers using intraocular magnifying lens. Factors predisposing the decomposition: inadequacy of fusion reserve, general disability, and lower vitality, psychosis, neurosis, mental stress, precision of job, advancing age. Symptoms depending upon the symptoms, heterophoria can be divided into compensated and decompensated. Compensated heterophoria is associated with no subjective symptoms. Compensation of heterophoria depends upon the reserved neuromuscular power to overcome the muscular imbalance. Individuals' desire for maintenance of binocular vision. Decompensated heterophoria is associated with multiple symptoms, which may be grouped as under. Symptoms of muscle fatigue. These result due to continuous use of reserved neuromuscular power. Headache and eye ache after prolonged use of eyes. Difficulty in changing the focus near to distance. And then photophobia due to muscular fatigue is not relieved by using dark glasses but relieved by using closing one eye. Symptoms of failure to maintain binocular single vision, blurring or clouding of words while reading, intermittent diplopia due to temporary manifest deviation under condition of fatigue, intermittent squint, which is usually noticed by patients, close relation or friends. Symptoms of defective postural sensation cause problems in judging distance and position displaying the moving object. This difficulty may be experienced by cricketers, tennis players, and pilots during landing. Examination of case of heterophoria. Testing for vision and refractivity is most important because a refractive error may be responsible for symptoms of patient or for deviation itself. Preferably, refraction should be performed under full cycle vision, especially in children. Cover and test. It tells about the presence of type of heterophoria. To perform it, one eye is covered with an occluder and the other is made of fixed object. In the presence of heterophoria, the eye under cover will deviate. After a few seconds, the cover is quickly removed and the movement of the eye which was under cover is observed. Direction of movement of the eyeball tells the type of heterophoria, and speed of movement tells whether recovery is slow or rapid. Prism cover test, Maddox dot test. In Maddox dot test, patient is asked to fix on a point of light in the center of Maddox tangent scale at a distance of 6 meters. A Maddox rod consists of many glass rods of red color set together in a metallic disc. Is placed in front of one eye with axis of rod parallel to axis of deviation. The Maddox rod converts the point light image into a line. Thus, patient will see a point light with one eye and red line with other. Due to dissimilar images of two eyes, fusion is broke and heterophoria becomes manifest. The number on Maddox tangent scale where the red line falls will be amount of heterophoria in degrees. In the absence of Maddox tangent scale, Dissociation between the point light and red line is measured by superimposition of two images by means of prisms placed in front of one eye with apex towards the fovea. Maddox swing test. This is Maddox swing test. Maddox swing is an instrument by which the amount of fovea for near at a distance 33 cm can be measured. It is also based on basic principle of distribution of fusion by dissimilar objects. The instrument is designed in such a way that through its two slits, right eye sees a vertical white arrow and a horizontal red arrow, and left eye sees a vertical horizontal line of numbers. The patient is asked to tell the number of horizontal line which vertical white arrow is pointing, the number on vertical line at which red arrow is pointing. The cyclophoria is measured by asking patient to align the red arrow with horizontal line of numbers. Measurement of convergence. Measurement of convergence and accommodation is important in planning the management of heterophoria. Maddox rod test for horizontal A and vertical B heterophoria, orthophoria, esophoria, exophoria, orthophoria, hypophoria, and exophoria. This is Maddox swing test. Then Maddox swing test. Measurement of fusion reserve. It can be done with help of synaptophore, prism bar, vertical fusion reserve, horizontal negative fusion reserve, horizontal positive fusion reserve. Treatment described below is indicated mainly in patient decomposition of heterophoria. Correction of refractive error when detected is most important. It may correct the phoria or relieve the symptoms. Orthoptic treatment is indicated in patients with heterophoria without refractive error and in those where heterophoria are not corrected by glasses. Aim of orthoptic treatment is to improve convergence, efficiency, and fusion reserve. Prescription of prism in glasses. It may be tried in selected cases of hyperphoria and in troublesome cases of esophoria and exophoria. Prism is prescribed with apex towards the direction of phoria to correct only half or at the most 2/3 of heterophoria. Surgical treatment is undertaken by patients with marked symptoms which are not relieved by other measures. Aims of surgical management is strengthen the weak muscle or weaken the strong muscle. Concomitant strabismus. It is a type of manifest squint in which amount or deviation of squinting eye remains constant in all directions of gaze. There is no association limitation of ocular movements. Etiology is not clear. As we know, binocular vision and coordination of ocular movements are not present since birth but are acquired in the early childhood. But the process starts by age of 3 to 6 months and is completely up to 5 to 6 years. Therefore, any obstacle in the development of this process may result in concomitant squint. Sensor obstacle. These are factors which hinder the formation of clear image in one eye. These single refractive errors, prolonged use of incorrect spectacles, anisometropy, corneal opacity, anterior opacity, disease of macular, optic atrophy, obstruction of pupillary area due to congenital ptosis. Minor motor obstacles. These factors hinder the movements of two eye in the correct position, in primary gaze and during ocular movements. A few such factors are congenital abnormalities of shape and size of orbit, abnormalities of extraocular muscles such as faulty insertion, faulty innervation, mild paralysis, abnormalities of accommodation, convergence and AC ratio. Central obstacle. These may be in the form of deficient development of fusion faculty, abnormalities of cortical control of ocular movements as occur in mental trauma, hyperexcitability of central nervous system during teething. Clinical features of concomitant strabismus in general. Cardinal features are, however, clinical features of concomitant strabismus are as given below. Ocular deviation, unilateral monocular squint, alternating squint, inward deviation, esotropia or outward deviation, exotropia or vertical deviation, hypertropia. Primary deviation, squinting is equal to secondary deviation, deviation of normal eye under cover when patient fixes the squinting eye. Ocular deviation is equal in all the directions. Ocular movements are not limited in any direction. Refractive error may or may not associated. Suppression amblyopia, concomitant squint, infantile esotropia. Suppression and amblyopia may develop a sensory adapter to strabismus. Suppression may be monocular and altering amblyopia develops in monocular strabismus only and is responsible for poor visual acuity. AV patterns may be absorbed in horizontal strabismus. When AV patterns are associated with horizontal concomitant strabismus become vertically incombinant. Types of concomitant squint: convergence squint, divergence squint, vertical squint. Convergence squint. Concomitant convergence squint or esotropy denotes inward deviation of one eye and is most common type of squint in children. It can be unilateral or alternating. Either of eyes deviate inwards. Clinical etiological types. Depending upon the clinical etiology features, converging concomitant squint can be further classified into infantile esotropia, previously called congenital esotropia, is characterized by following features. Age of onset is usually 1 to 2 months of age but may occur any time in first 6 months of life. Angle of deviation is usually constant and fairly large. Fixation pattern. Binocular vision does not develop. There is alternate fixation in the primary gaze, cross fixation in lateral gaze. Amblyopia develops in 25 to 40% cases. Association include inferior oblique overaction, dissociative vertical deviation in about 70 to 90% cases. Treatment: surgery, ambulatory treatment by patching normal eye should be always done before performing surgery. Recession of both medial recti is preferred over unilateral resect procedure. Time of surgery should be done between 6 months to 2 years, preferably 1 year. Accommodative esotropia. It occurs due to overaction of convergence associated with accommodation reflex. Accommodative esotropia is most common type of squint in children. When esotropia develops around 2 to 3 years of age, it is most like accommodative. It is of 3 types: refractive, non-refractive, mixed, refractive, non-refractive, mixed. Refractive is usually developed at the age of 2 to 3 years and is associated with high hypermetropia, 4 to 70. Mostly it is for near and distance vision and fully corrected by use of spectacles. Fully corrected by accommodative esotropy corrected by spectacles. Non-refractive accommodative esotropy, it is caused by abnormal AC by a accommodative convergence by accommodation ratio. This may occur even in patients with no refractive error. Esotropy is greater for near than for distant. It is fully corrected by bifocal lens with the addition of +3 diopters for near vision. Myotics may be useful in younger children, not suitable for bifocals. Myotics facilitate accommodation and thus reduce the accommodative convergence. Mixed accommodative esotropy, it is caused by combination of hypermetropy and high AC by A ratio. Atropia for distance is corrected by correction of hypermetropy. Residual esotropia for near is corrected by addition of 3ds lens. Acquired non-accommodative esotropia, essential acquired or late onset. Essential acquired or late onset. Basic type: convergent excess, divergent insufficiency. Sensory esotropia results from monocular lesions in childhood which either prevent the development of normal binocular vision or interfere with maintenance. Example of such lesions are cataract, several congenital dropsies, aphakia. Divergent squint. Clinical types: congenital exotropia, primary exotropia. Congenital is rare, almost always present at birth. It is characterized by a fairly large angle of squint, usually ordered with homonymous fixation in lateral gaze and no amblyopia. Primary exotropia, it may be unilateral or alternating, may present as intermittent or constant exotropia. Intermittent exotropia is thus most common type of exodeviation with following features. Angle of onset is usually early, between 2 to 5 years. Deviation becomes manifest as times later than others. Constant esotropia, if not treated in time, intermittent exotropia may decompensate to become constant exotropia. Types: convergence insufficiency, divergent excess, basic non-specific. Secondary exotropia, it is constant unilateral deviation which results from long-standing non-ocular lesions. Consecutive exotropia, it is a constant unilateral exotropia which results either due to surgical overcorrection of esotropia. Evaluation case of concomitant strabismus. Patient with primary exotropia, direct cover test depicting left exotropia. Examination. History, meticulous history is very important. It should be include age, duration, age of onset and duration, mode of onset, any illness preceding squint, intermittent of or constant unilateral or alternating, history of diplopia, family history of squint, history of head tilt or turn, and so on. Examination. Inspection. Large degree squint is obvious on inspection. Ocular movements, both unilateral as well as binocular movements, should be tested in all cardinal patients of gaze. Pupillary reaction, these may be abnormal in patients with secondary deviation due to disease of retina and optic nerve. Median fundus examination. Testing of vision and refractive error, it is most important because the refractive error may be responsible for symptoms of patient or for deviation itself. Cover test, direct cover test, it confirms the presence of manifest squint. To perform it, the patient is asked to fixate on point source of light is fixated, then the normal looking eye is covered while observing the movement of uncovered eye. In presence of squint, the uncovered eye will move in opposite direction to take fixation, while in apparent squint there will be no movement. And presence of squint there will be movement. The test would be performed for near fixation 30 cm as well as distant fixation 6 meter. Alternative cover test reveals whether squint is unilateral or alternate and also differentiate concurrent squint from parallax squint. Estimation of angle of deviation. It's by corneal reflex. It is a rough but handy method to estimate the angle of manifest squint. In it, the patient is asked to fixate the point and do the test. Then light held at distance 30 cm. Deviation of corneal light reflects from central of pupil is noted in squinting eye. Roughly the angle of squint is 15 degree and 45 degree when the corneal light reflex falls on the border of pupil and limbus. The prism and cover test. Prisms increasing strength with apex to a deviation are placed in front of one eye. The cover and uncover is performed till there is no recovery movement of eye under cover. Krimsky corneal reflex. This one is worth 4 test. Hitchberg corneal reflex test. Krimsky corneal reflection. In this test, the patient is asked to fixate on a point of light, and prisms of increasing power are placed in front of normal eye, fixating eye till the corneal light reflex enter in the squinting eye. Measurement of deviation with synoptophore. All types of heterophorias and heterotropias can be measured accurately with it. In addition, many other tests can be also be performed with this instrument. Tests for grade of binocular vision and sensory function. 3 grades: suppression, amblyopia, abnormal. Worth 4 test. For this, patient wears goggles with red lens in front of right and green lens in front of left eye, and views of box with 4 lights, 1 red, 2 green and 1 white. Interpretation: in normal binocular vision, the patient sees all 4 lights in the absence of manifest squint. Abnormal retinal correspondence: patient sees 4 lights even in the presence of manifest squint. Left suppression: the patient sees only 2 red lights. Right suppression: patient sees only 3 lights, 3 green lights. In alternating suppression, the patient sees 3 green lights and 2 red lights. In diplopia, the patient sees 5 lights, 2 red and 3 green. Test for fixation: it can be tested with help of visuoscope or fixation thorough ophthalmoscopy. After image testing, the test for right fovea is stimulated with a vertical and left with a horizontal bright light. Interpretation: a patient with normal retinal correspondence will draw across. An esotropic patient with abnormal retinal correspondence will draw vertical image to left of horizontal. Types of fixation: central fixation, parafoveal, macular, paramacular, peripheral, synoptophore, After image test, a normal retinal correspondence, esotropy with ARC, optical principle of synoptophore. Sensor function test with synoptophore. Synoptophore consists of 2 tubes having right angle bent. Treatment of concomitant stiffness. Goals of treatment: to achieve good cosmetic correction, to improve visual acuity, to maintain binocular singulation. Treatment modalities: spectacles with full correction of refractive error should be prescribed in each and every case. It will be improve the visual acuity, at times may correct the squint partially or completely. Occlusive therapy, as indicated in presence of amblyopia. After correcting the refractor, the normal is occluded and the patient is advised to use the squint eye. Regular follow-ups are done in the squint clinic. Occlusion help to improve the vision in children below 10 years. Pre-operative orthoptic exercise, squint surgery. The basic principles are: weaken the strong muscles by recession or strengthen the weak muscle by resection. Type 1 amount of muscle surgery. It depends upon the type 1 angle of squint, age of patient, duration of squint and visual status. Post-operative orthoptics, these are required to improve functional range and maintain binocular singulation. In concomitant squint, it is a type of heteropia in which the amount of deviation varies in different directions of gaze. It includes following: parietic squint, A and B pattern heterotropias, restrictive squint. Paralytic strabismus. Etiology: the lesion may be neurogenic, myogenic or levels of neuromuscular junction. Neurogenic lesion. Neurogenic may occur at the level of nerve nucleus, nerve root or any part of nerve in its course. Nuclear ophthalmoplegia refers to paralysis of extraocular muscle due to lesions of third cranial nerve. They are more often bilateral. Common cause: congenital inflammatory lesions, neoplastic lesions, vascular lesions. These are known in patients with hypertension, diabetes and atherosclerosis. Then traumatic lesions. These include head injury, direct or indirect trauma to nerve trunks, toxic lesions, demyelinating lesions, myogenic lesions, congenital lesions, traumatic lesions, inflammatory lesions, myopathies, bilateral ptosis, diplopia. Other associated symptoms of CPO. Diplopia is double vision. Clinical feature: diplopia. Diplopia is the main symptom of paralytic squint. It is more marked in field of action of paralyzed muscle. It may be crossed, it may be horizontal, vertical or oblique depending upon the muscle paralyzed. Diplopia occurs due to formation of image on dissimilar points of two retina. Confusion: it occurs due to formation of image of two different objects on corresponding points of two retinae. Nausea and vertigo. These results from diplopia, and confusion may cause vomiting also. Ocular deviation is typically a sudden onset. Signs: primary deviation of affected eye and is way away from the action of paralyzed muscle. Example, if lateral rectus paralyzed, the eye is converged and angle of deviation varies in different direction of gaze. Secondary deviation, it is deviation of normal eye seen under cover when the patient is made to fix with squinting eye. It is greater than primary deviation. This is done due to fact that the strong impulse of innervation required to enable the eye with paralyzed muscle to fix is also transmitted to yoke muscle of sound eye, resulting in a greater amount of deviation. This is based on Hering's law of equal innervation of yoke muscle. Restriction of ocular movement occurs in the direction of action of paralyzed muscles. Compensatory head posture. It is adopted to avoid diplopia and confusion. Ocular torticles refers to tilting of head, chin depression occurring due to compensate for the vertical diplopia. It needs to be differentiated from two torticles occurring due to undue contraction of sternocleidomastoid muscle. False projection of orientation. It is due to increased innervational impulse conveyed to paralyzed muscle. Pathological sequelae of extraocular muscle palsy. A patient with third cranial nerve palsy showing ptosis and divergent squint. Clinical varieties of ocular palsy: isolated muscle paralysis of third cranial nerve, double elevator palsy, and total ophthalmoplegia, external ophthalmoplegia, internal nuclear ophthalmoplegia. Investigation of case of paralytic squint. Pathological sequelae of right lateral rectus muscle paralysis: overaction medial rectus, primary palsy lateral rectus, contracture medial rectus, secondary palsy lateral rectus. Investigation of case of paralytic squint, evolution of squint. The tests required are diplopia charting. It is indicated in patient with complaining of confusion or delusion. In it, patient is asked to wear red and green diplopia charting glasses. Red glass being in front of right eye, or green in front of left eye. In semi-dark, he is shown a fine linear light from distance. Asked to comment on image in primary and position. In other position of gaze, patient tells about the position and separation of two images in different fields. 14.27. Binocular image, right image, left image. Diplopia chart of patient with right lateral rectus palsy. His screen. Then his screen test tells about the paralyzed muscle and his chart in right lateral rectus palsy. The pathology sequelae of paralysis is overaction, contraction, secondary inhibition. Palsy. The two charts are compared. The small chart belongs to high eye with paratic muscle and larger in the eye with overacting muscle. Paratic and overacting. Field of binocular fixation. It should be tested in patient with paralytic squint where applicable. That is, if patient has some field of single vision, the test is performed on perimeter using a central chin test. Force deduction test. It is performed to differentiate between incomplete squint and due to paralysis of extraocular muscle, and that due to mechanical restriction of ocular movements. FTT is positive in case of incomplete squint to mechanical restriction, and negative in case of extraocular muscle palsy. Management. Treatment of cause, conservative measures, treatment of annoying diplopia, chemodenervation of contralateral muscle with botulinum toxin. Features: paralytic and non-paralytic squint, suddenness, low, present, absent, diplopia, ocular movements in limited direction, full, false projection. It is positive, false projection negative. Head posture, particular head posture depending upon the muscle paralysis may be present. Normal. Nausea and vertigo present and absent. Secondary deviation more than primary deviation, equal to primary deviation. In old case, pathological sequelae in the muscle present. This is absent. A and V pattern heterotropia. A and V ectotropia. In A esotropia, the amount of deviation increase in upward gaze and decrease in downward gaze. The reverse occurs in V esotropia. A and V exotropia. A exotropia, the amount of deviation decrease in upward gaze and increase in downward gaze. Reverse occurs in V exotropia. Etiology: oblique muscle of dysfunction is the commonest cause. Other causes include horizontal rectus muscle dysfunction. Clinical presentation. Treatment: weakening of overacting oblique muscle, transposition of horizontal rectus muscle, middle rectus air transport towards apex, male lateral rectus air toward empty space. Given figure 40.29. Then restricting squint. Extraocular muscle is not paralyzed, but its movement is mechanically restricted. Characteristic features are smaller ocular deviation, positive force duration test. Common causes: Dione retraction syndrome, Brown superior oblique tendon sheath syndrome, strabismus fix, dysthyroid ophthalmopathy, incarceration of extraocular muscle, Dione's restriction syndrome. Then characteristic features are limitation of adduction, retraction of globe, eye in prima patient, brown superior optic tendon sheath syndrome, establishment fixes, establishment surgery, muscle weakening procedure, include recession, margin myectomy, muscle centering procedure change direction of muscle action. Steps of recession: muscle is exposed by reflecting flap, overlying conjunctiva, tendons capsule. Two vicryl switches are passed through outer quarters of muscle tendon near the incision. Muscle tendon is disintegrated on sclera with help of tenotomy scissor. The amount of recession is measured with calibration marked on sclera. Muscle tendon switched with sclera at marked side posterior to original incision. Conjunctive flap is switched back. Steps of recession: muscle is exposed as far as recession, and the amount to be resected is measured with calibration marked. Two absorbable switches are passed through outer quarters of muscle at marked site. The muscle tendon is inserted from sclera and portion of muscle anterior to switches is excised. Muscle stump is switched with sclera at original insertion site. Congenital flap is switched back. Nystagmus definition features. Techniques of resection. Nystagmus is defined as regular and rhythmic to and fro involuntary oscillatory movements of the eyes. Then it may be characterized by any of the following features. It may be pendular or jerk nystagmus. In pendular nystagmus, movements are of equal velocity in each direction. It may be horizontal, vertical, or rotatory. In jerk, the movement may be slow component in one direction and fast component in other direction. The direction of jerk nystagmus is defined by direction of fast component phase, and it may be right, left, up or down or rotatory. Nystagmus movements may be rapid or slow. The movements may be fine or coarse. Nystagmus may be latent and manifest. Pathogenesis and classification. Nystagmus occur due to disturbance of the factors responsible for maintaining normal ocular pressure. These include disorders of sensory visual pathway, vestibular apparatus, semicircular canal, midbrain, and cerebellum. Many classifications are in vogue for nystagmus. A simple classification modified from classification of eye movement abnormalities, strabismus, CMOS is as below. Physiological nystagmus, optokinetic nystagmus, endpoint nystagmus, physiological vestibular nystagmus, pathological nystagmus, nystagmus of infancy, infantile nystagmus syndrome, fusion maldevelopment nystagmus syndrome, spasmus Newton syndrome, acquired nystagmus, nystagmus due to disorders of visual fixation, nystagmus due to vestibular imbalance, acquired pendular nystagmus. Physiological nystagmus occurs normally in a variety of situations, include optokinetic nystagmus and end gaze nystagmus and physiological vestibular nystagmus. Optokinetic, it is a physiological direct nystagmus induced by presenting to gaze the object moving serially in one direction, such as strips of spinning optokinetic drum. The eyes will follow a fixed strip momentarily, then jerk back to reposition centrally to fix up a new strip. Similar condition occurs while looking at outside things from moving train. End gaze nystagmus, it is a fine jerk horizontal nystagmus seen in normal persons on extreme right or left gaze. Physiological vestibular nystagmus, it is jerk nystagmus. It is a vestibular ocular reflex which can be elicited by stimulating the tympanic membrane with hot or cold water. It forms basis of coloritis. If cold water is poured into right ear, patient develops left jerk nystagmus, rapid phase towards left, while the reverse happens with warm water. The patient develops right jerk nystagmus. It can be removed with mnemonic cause. Cold opposite, warm same. Pathological nystagmus of infancy, seen in childhood beginning in infancy, therefore are not congenital or believed earlier. Infantile nystagmus syndrome is the new name given in the CMOS. Etiology may be idiopathic or associated with synthetic deprivation, ocular albinism, aniridia, labor, congenital pneumorosis. Other causes include bilateral congenital cataract, achromatopsia, congenital stationary night blindness, bilateral optic nerve hypoplasia. Characteristic feature: it is by erratic waveform. CMOS criteria for INS: infantile onset, ocular motor recording show accelerating surface. Waveforms may change in early infancy. Head posture usually evident by 4 years of age. Common associated findings: progression from pendular to jerk. Family history often positive. Null and neutral zones present. Maldevelopment nystagmus syndrome, FMNS. Characteristic feature: infantile onset, associated strabismus. Intensity decrease with age. Nystagmus not present when both eyes are open. It appears when one eye is covered. Becomes manifest under monocular viewing condition in the presence of decreased vision in one eye, as in anisymmetric amblyopia. It is a jerk nystagmus with rapid phase towards the uncovered eye. Low amplitude pendular nystagmus, dual jerk waveform. Spasmus Newton syndrome is third most common nystagmus in infancy. Character feature: infantile onset abnormal head posture and head oscillation which improve during childhood. Normal MRECT, a visual pathway, ocular motility recording high frequency. Acquired nystagmus: late onset or acquired nystagmus usually characterized by oscillopsia, often associated with other neurological problems. Acquired nystagmus include nystagmus due to disorders of visual fixation, also called visual loss. Nystagmus may occur due to disease of affecting any part of visual system from retina to visual cortex or condition interrupting visual projection to pons cerebellum as below. Nystagmus in disease of retina, nystagmus in disease of optic nerve. Nystagmus caused by vestibular imbalance, peripheral vestibular nystagmus, central vestibular nystagmus, and nystagmus due to disorders of glaze holding. Peripheral is fast phase away from the side of vision. It improves fixation, worsens with gaze towards fast phase. It is also with distraction lesions, vestibular systems such as labyrinthitis and vestibular neuritis. Upbeat nystagmus in primary position of gaze in the fast component is upward. Downbeat nystagmus in primary position of gaze, fast component is downwards. It is usually with posterior fossa disease and is typically of compression at the level of foramen magnum. Arnold-Chiari syndrome. It is usually associated with brainstem cerebral disease. C-star nystagmus features in it one eye is up and intarts. Cause it is usually associated with upper brainstem lesions. Periodic alternating nystagmus features conjugate horizontal jerk nystagmus present in the primary is characterized by spontaneous direction changes every 60 to 90 seconds. Nystagmus due to disorders of gaze holding. Then dissociative conjugate nystagmus. Convergent retraction syndrome, Bruns nystagmus, centripetal rebound nystagmus. Cause of rebound nystagmus include cerebral disease, lateral medullary infection, tumors confined to flocculus, nystagmoid movements, ocular flutter, ophthalmos superior oblique myoclonia, ocular bobbing.